All right, let's get started. Welcome. My name is Catherine Lohide, and I'm the Senior Vice President of Marketing at FORMSTACK. We're excited to host today's roundtable focusing on lessons learned from the front lines of the COVID-19 vaccine rollout. Before we dive in with our panelists, let me give you a little background on FORMSTACK. For 15 years, we've helped more than 27,000 organizations reimagine work and the patient experience with our workplace productivity platform. We currently work with organizations across the country to develop HIPAA-compliant COVID-19 screening and vaccination workflows, from collecting patient consent to getting registrations, using our digital forms, document automation, and e-signature solutions. We're excited to learn more from our esteemed speakers today. We also have some housekeeping items to ensure today's session runs smoothly. Please submit questions through the Zoom Q&A feature. We'll get through as many as we can at the end of today's discussion. We'll also send a recording of today's event in the coming days. Now I'll hand it off to our moderator and Fortune reporter, David Morris, to introduce our panel.
Hello, everyone. I hope my video just actually turned on. Thanks for coming today. My name is David Morris. I cover technology at Fortune and recently have been focused a lot on the vaccine rollout. Rather than me introducing our three panelists, what I'd like to do is actually start with a question, have each of you introduce yourself while you're answering it. And the question is, we've had a lot of problems with the US vaccine rollout, but I think we've also seen a lot of improvements in the process over the last 3 months. So what I'd love is for each of our panelists, and we can maybe start with Dr. Dai, just introduce yourselves and offer what you think might be the most significant improvement in the vaccine rollout of whatever dimension that you've seen over the last 3 months. So just introduce yourself and what you think is the biggest improvement we've made in the US vaccine rollout. So Dr. Dai, please go on ahead.
Hello, everyone. My name is Lung Dai, and I'm associate professor at the Johns Hopkins University, Harvard Business School. I've been following vaccine rollout very closely. But the question from David is actually a very tough one. You talk about 3 months. I think you should reduce that time frame to probably 3 days or even 3 hours, because it has been such a fluid situation. Every day has been very, very different. I got to say that the first month, we were struggling with slow rollout because of a lack of vaccination capacity. Then I think the capacity increased, but then we worried about the lack of supply and also lack of effective way of connecting doses with people, with our portals, etc. And right now, we look back, we say that actually we're doing a great job. Actually, US now is actually leading the world in terms of COVID-19 vaccination. And next stage, we probably have to worry about how to get people to be willing to vaccinate it. So we're facing very different challenges on a weekly basis, on a daily basis. So I'm very excited to hear about the perspectives from our fellow panelists.
And Dr. Heltz, would you like to go ahead and introduce yourself? And if there's something that you want to highlight that has been an improvement, we'd love to hear about it.
Yeah, hi everybody. This is Monica Heltz, and I am the director of a municipal level local health department in Fishers, Indiana. And so I am intimately involved on the ground level with rolling out vaccine. And I would say, I think Dr. Dai stated it pretty well in that, initially our biggest constraint is supply of vaccine, and, just being anxious. We've made our plans, we're ready to implement things, and we're still waiting for a vaccine. We're just now here on the ground level in Indiana, at least, starting to see the supplies increase to the level that now we're starting to look towards our capacity and what is our maximum capacity to be able to provide those vaccines now that they're more freely available, or that they will be very soon. So we're trying to see how big we can go and how fast. And then the next stage after that is, as Dr. Dai mentioned, is obviously going to be, okay, now when we've given the vaccines to everybody who really wants one, how do we convince the people who are on the fence that they really ought to get the vaccines as well?
Great. And our final panelist is Douglas Havron. Doug, if you could introduce yourself.
Yes, I'm Douglas Havron. I'm the Director of Public Sector here at Coastal Cloud and a member, a clinician, I should say, for a number of years. And so I'm excited to be here and talk about this from a clinical perspective as well as using technology. From my perspective, the largest challenge we've had has really been able to facilitate the registration of individuals for vaccine appointments. We've seen a number of smaller technology solutions that have really been used because they were cheap and easy to reach, but they've complicated and failed. We've seen even large technology solutions become overwhelmed. And so I think one of the largest challenges we've had is looking at our strategic national stockpile plans and our past pandemic plans and how we really did test, train, and drive towards implementing those on a large scale. And with COVID-19 morphing and the priorities changing because the virus has changed, that has further complicated that mass registration, mass appointment, mass access, if you will, to the vaccine, which Dr. Heltz mentioned is also complicated with allocation restrictions.
Mm. Yeah, thank you for bringing up signups. You actually set up my next topic perfectly. So early on, as you mentioned, some of the signup systems for vaccine were sort of cobbled together, sometimes fairly primitive and not that robust. One of the major problems was also that big batches of doses were getting dropped kind of all at once, and it gave a lot of advantages to people who were able to sit there and refresh web pages, and that might, I think, have contributed to some of the problems with vaccine equity that we've seen. At least one solution is what's called pre-registration. I know that it has been expanding, but could Doug or Monica, if either of you would like to maybe talk a little bit about pre-registration, the differences between that and what we kind of started off the drive with, and how the progress on that and other ways of making online signups a little bit more effective are going.
So I can speak a little bit to that just from the unique perspective of here in Indiana. I know that we've seen a lot of stories across the country of the long lines of people waiting for appointments and having these walk-in clinics. Indiana has never done that. So we have had pre-registration the entire time. It's not to say that it's not been without some challenges. The systems have crashed when a new group has been opened up. So on the ground, we have to be ready with supplemental paper forms when the system crashes because we're having so many people pre-register. But it has facilitated things a lot as far as having that system and structure in place from the beginning.
Yeah, I would agree. The registration component or the pre-registration versus the appointment scheduling, right? So I often equate it to, many times we roll these out like Elton John tickets, right? The everyone is trying at the same time. And what we have found in our experience that it's much better from a throughput perspective, from a load balancing technology perspective, that we allow people to pre-register and then have targeted campaign messaging out to those individuals who now qualify based upon age, based upon position, role in the community, first responder, those types of things. And so the greatest access or success that we have had is really expanding those technology platforms to be extremely robust. Our partners use other solutions and as well as solutions to do signatures and registration and electronic components to consents. But the bottom line has been the success of allowing people to register on a routine basis, and then as vaccine allocation becomes available, targeting those messages to those individuals who most qualify and facilitating that registration. Now, we have to keep in mind, as you mentioned in your question, access equality, and whether that be offering languages, different languages for our technologies, whether that be offering technology that's 508 compliant, functional access needs, concerns, as well as offering that and call center capabilities so that individuals with different languages, different functional needs have equal access to the same registration and timeline for scheduling of appointments.
And Doug, kind of big picture, do you have a sense of, we're talking about state systems, different pharmacy systems. Obviously, we have a lot of different systems. Do you have a sense of how much progress has been made going away from that Elton John ticket model towards things that are a little bit more smooth, you might say?
Yeah, I think in our experience, we've certainly moved into a different mindset with our client in the state of Florida, particularly, and where registration. If you saw the governor's executive order today, that number, access to vaccine will go down beginning Monday and go down the following Monday, and so what we've seen is a much more stable registration component, and then the rollout of scheduled vaccine appointments and allocation has become more of a routine rather than we finally got it right. And much of that comes with just the federal allocation process, right? Nothing against anyone. The vaccine was approved and now suddenly it's available. And so there's inherently that spike. So from other systems, what we have seen in discussions with many prospects and many clients is individuals have moved away from the standard. Now we have, or I shouldn't say the standard, the atypical. Now we have vaccine. Let's see this large rush because the vaccine allocation process has stabilized. We're able, the jurisdictions are able to predict what's coming next week or the week after, and therefore their processes have allowed them to kind of settle in, if you will, into a process rather than scramble because it's finally here or the next one was just released, etc.
Yeah, the supply chain transparency has been, I think, one of the big improvements of the last couple of months. And you mentioned this relationship between federal distribution and state and other administrators. I don't know exactly how unique it is, but certainly one of the fairly unique parts of the US rollout is this federal structure where at least for a good part of our time during the pandemic, the federal government was leaving a lot to the states, and that has continued to a great degree through the rollout. I, for one, I'm surprised that we have turned out to be so successful given this fragmentary approach. So I guess I have a very large scale question for each of you, which is, has this federalism proved to be in some way an advantage that we weren't expecting, or is the U.S. Success so far mainly about just having the vaccine? And maybe we can start with Dr. Dai.
Well, that's a very broad question, but I like federalism. I like the idea that we have 50 states plus DC. And so really one way of looking at it is that we allow states to learn from each other. I started writing about West Virginia, I think in December. And so this is a state, even their governor talk about West Virginia being a relatively poor and backward state, that being looked down upon by many others. But they have achieved a huge success in vaccination. They have challenged a lot of stereotype, a lot of pre-assigned notion about what is needed for vaccination success. So now I'm comparing Maryland, which I live in, versus West Virginia. Maryland is among the wealthiest states and in the US, but our vaccination performance is just not even close to West Virginia, and neither state is big either. So going back to the idea of pre-registration versus sign-up model, I've been writing about this for quite a while, and West Virginia, they started doing pre-registration portal in early January. I have no idea who gave them this idea, but they were so advanced in this idea of pre-registration, because the idea of pre-registration is to let vaccine come to people rather than forcing people go to vaccine time and again, right? You have every morning you get up or check hundreds of websites. That's what Marylanders have been doing over the past crazy 3 months, and it's not getting better either. And so I really think, back to your question, I really think federalism really gives people a lot of things to examine, a lot of things to compare, so we learn from each other. Now, because we have such a great neighbor, and Maryland leaders are being actually compelled to deliver promise. I think we have been doing better, in part because people cannot help comparing. And we're learning from each other. It's like the largest controlled experiment in vaccination campaigns. We have everything in human history, and comparing Israel versus UK from US. Oh, but you come back, oh, come on, Israel is such a small, tiny country, have only 7 million people, almost like New Jersey, but it's within the United States, and we can compare different states, and we can compare neighbors, right? And so I do think this is an advantage, because to me, this is a learning experience, and the vaccination is about learning, because this is very new to everyone. And 1 year ago, if you ask me, is it possible we are distributing mRNA vaccines or Johnson & Johnson vaccine now, I would tell you that you are crazy. This is probably too much, too adventurous, and too optimistic. But now, the fact that we're distributing multiple vaccines, this is a miracle. So we're delivering this miracle, which is a novel experience. So which is why learning helps, which is why I'm a big fan of different states having different practices, but then we can learn from each other.
Monica, what does that look like for you at the local level, especially this idea that states are able to learn from each other because they're using different strategies?
So at the local level, it can be kind of frustrating because we are the ones tasked with enforcing the specific rules. So, our state sets rules, and then somebody from another state may come and say, because the people are flying all over the place that are desperate for a vaccine, right? So they may come in, especially if you're in a border town or, somewhere on the edge of another state that has a very different set of rules and criteria, then people may come over, and it's the people at the ground level that are then forced to try to enforce these rules that the state has set and these expectations that the state has set. And, that can be very difficult, and people aren't always, not everybody can do that. Not everybody's got the temperament to do that. And health departments aren't used to having to turn people away for any reason, so. Yeah. It has been interesting, especially, as we've gone these different routes. Indiana took an age-based criteria almost exclusively. Some other, states nearby, chose to vaccinate teachers, for example. So there's this, disconnect and a lot of pressure, and a lack of understanding on who actually makes the rules. So we get pressure from our population saying, why can't you vaccinate me? Well, it's not us that's allocating this vaccine and making these rules.
Yeah. Doug, did you want to chime in on that question?
Well, I think, your question about federalism versus the states, and, it's important for us to look at the way in which emergency management responds in the United States, and the federal government is the support mechanism to the home rule state, right? And so in some states, those that are home rule states further pass that responsibility, that jurisdictional authority down to the local elected official or local authority having jurisdiction, as we would call it. And so I think it's important that we recognize that's the world we live in. That's the way in which our emergency response system works here, whether that be FEMA, whether that be local emergency management, or whether that be state and county health department. The thing that I think it allows us to navigate those different jurisdictions' decisions and those different necessary requirements based upon the outbreak, the pandemic in their particular jurisdiction, is providing technology solutions. Here at Coastal Cloud, we love to look at large scale technology solutions that can navigate the environment for which we need to just help support. So if that's providing short codes for individuals to get vaccinated because they meet certain criteria, like Monica mentioned, of different roles or different jobs, or providing a large scale platform that allows for pre-registration or allows for us to quickly configure a different age so that tomorrow a different age group can get that. That's been our way of tackling this, because it is the environment for which our emergency management and health response system operates here in the United States. And I don't think it's changed. I think it's a matter of all of them have been activated at the same time, and they've been all activated for a period of time that's far beyond any other response we've ever done.
So to drill into one particular element of the federal approach that Monica referenced, states have had different thresholds, some very different for age or other requirements. There was some recent research, and someone might have to remind me where it came from because I'm forgetting, but recent research showing that states that opened up much more broadly early actually wound up having slower state rollouts because, at least according to this research, there were bottlenecks and disruptions. I guess this is primarily a question for Ting-Long and Monica, but I'm curious kind of what your view, whether you can maybe provide some insight into, and Monica, just to put it in context, in Indiana, you're well above the national average at nearly 15% vaccination at this point. So Indiana is doing well with its strategy. But what is the, how do we understand this strange phenomenon where we have broad opening that seems to actually slow down the vaccination process, at least according to some preliminary research? Maybe Dr. Dai, would you like to take a stab at that one first?
Oh, sure. First of all, I need to look at the study. I look at the determinants of efficiency vaccine rollout, the hundreds of factors, and none of them seems to be conclusive. For example, people ask me, why would rural states doing better than urban states? I said, I need to look at the data. Look at the data, actually, it's not even close. Actually, the correlation is like very weak. So I need to look at the study to be able to answer that. But my understanding is that states with better state level coordination, they do not dedicate everything to counties, to healthcare providers, they tend to be doing better. And because it's just that when you have more layers and things are going to slow down. And so when you have more centralized, I mean, this is very paradoxical, right? On the one hand, I do think it's a good idea to let states decide what to do. But on the other hand, I do think at the state level, states, they should have a certain sort of coordination and centralization mechanism so that you do not just dedicate everything to local health departments who are underfunded and overutilized, honestly speaking. Yeah, so that seems to be my observation across the US. That seems to be true. I'm not sure about how you open the eligibility to a wide population, how that is going to change. One thing I can think of could be that if you open vaccine early on to people of a wider population, and then so that's to get more people get eligible, but you don't have the doses, and that's going to cause a lot of frustration. That's just cause a lot of friction, and people may get frustrated, and then what you're going to see, you're going to see a lot of variability in terms of matching supply with demand. And I don't have solid data and to look at this. I need to look at the study, but I do not see any clear correlation between these two.
And Monica, what are you seeing on the ground in terms of, or I guess maybe just what are your thoughts from the ground on that wider versus narrower pipeline approaches between the states?
So my thoughts on the ground, without knowing what every single state is doing, but just the perspectives that we're getting and have been shared with us, are that probably the single greatest factor that has helped us here has been having a centralized registration and scheduling and documentation system. So we all work out of the same exact system. With now the only exceptions really are the federal program pharmacy partners, the Kroger, Walmart, and Meijer. So until they came on, everybody had the same system, and for the most part, we all still do. So that allows for a little bit more consistency, a little bit less frustration as far as kind of not having to search all these multiple different sites. We can go to all one place. We're using a centralized call center also, where people can get phone help, and everybody's in that same system. Now that system crashes every time they open up a new group, but having that centralized system and walking down the age groups a little bit slower and more measured allows for one, like Dr. Dai mentioned, for local health departments we have some of the lowest funding rates in the country here in Indiana for local health departments, by the way. So most of them do not actually have electronic medical record systems. So they would not have had the capacity to even be able to document any of this in any form that would have had some kind of central application. So we wouldn't even know how many people have been vaccinated. So the ability for people to have received the vaccine and to get it into arms, really that centralized registration process was critical for us.
Great. So we're in the enviable position globally of being able to really look towards the future and even sort of getting to the sense that there is some end to this. However, one of the big obstacles facing the US that I think is perhaps less acute elsewhere is vaccine hesitancy, which comes in a lot of different forms, whether people are suspicious of the vaccine itself, afraid of side effects, unsure of its effectiveness. And the rates are quite high, but dropping fast. A Kaiser survey has the total hesitancy rate at 51% in January, and it was already down to 42% by February. So based on what you're all seeing, do you believe that that's going to continue dropping to a point where it will be less of a concern just as people see others getting vaccinated, for example? Or are there, strong steps based on what that we should be taking to address hesitancy to make sure that we can get to herd immunity and actually end the pandemic? And that's kind of for anybody who wants to chime in.
Yeah.
Well, go ahead. Go ahead.
I was just going to say that from the research that I've seen, and even to your point of that number being down, I think that number, in my opinion, that number is down because of access. And so what we've seen over and over again is that people are less hesitant to get the vaccine when it's readily available to them. And so we've seen that in a number of different communities, and we've seen employers start to talk about opening employer-specific vaccine initiatives in order to get their market back up and running and provide that access for their employees. So I think from a technology perspective, it's incumbent upon those that provide the technology solution to ensure that they're consistent and readily available. Monica is mentioning some challenges, but I think it's really important that individuals have access to register, access to see when vaccine is available to them, that those vaccination sites are within their communities or within easy access to their communities, and understanding some of those individuals have transportation challenges, et cetera. So, my opinion on this topic is as more vaccine becomes available and access to that vaccine becomes more tangible, the hesitancy will go down.
Yeah, I would like to add a few other components. So part of it is, the more people we get vaccinated that do just fine, then that also helps people feel better. They say, everyone around them is like, I've been vaccinated, I feel fine, everything's going great, so that is going to continue to decrease the hesitancy as well. In addition, what we've seen is as more vaccines become available, specifically, we had the Pfizer and the Moderna have one specific technology that they were developed under, and then the Johnson & Johnson is a different technology. So some people have a preference based on the technology that was used to develop those vaccines, and having more options also decreases the hesitancy because they may be nervous about one technology, but not about another.
Yeah.
So I think, so first of all, I think we have to, certainly there are certain people, whatever you do, they're not going to take vaccines. So I think that's not the emphasis here. Emphasis here is that for those who are willing or considering getting vaccinated, we should try to make things easier. Back to Doug's point, maybe reduce the friction, make things easier for them, right? What about giving people Uber credit for getting a vaccination? Or for those people who are really difficult to travel or get anywhere, what about we do vaccine home visits? This is not too crazy idea, honestly speaking, because the other day I went to Walgreens, they told me they're giving 20 COVID-19 vaccines every day. And so if you do 20 home visits, that's not a lot. I think this is something can be easily arranged. But the fundamental point is that I think we have to change the mentality that right now we're seeing people getting vaccinated. We feel like this is a benefit to them. But the reality is they're also contributing to society by getting vaccinated and by contributing to faster convergence to herd immunity. And so when you are receiving COVID vaccines, you're not just getting something, you're also giving to society. We should totally get rid of vaccine shaming, because right now, and for people like you and me, a lot of us, when you tell people you're getting vaccinated, you have to justify why you're getting vaccinated. People saying, okay, because you do, Or some people say that it's just because I have a higher than average BMI, stuff like that. There is still a sense of guilt associated with getting vaccinated if you're not a 65 plus, or if you're not a healthcare provider. I think we should really get this, make sure people feel like a sense of honor from getting vaccinated, or at the very least, we should get rid of all the frictions that make it harder for people to get vaccinated. So eventually changing from this pool system to asking people to go to these hundreds of websites day after day to check for slots. What about just to the UK or Israel system, and you basically let vaccines come to people, and changing from a pull system to a push system. So the question would be easy, right? Are you getting vaccine, not getting vaccine? And so I think doing whatever we can to reduce the friction in the vaccine system will help.
Catherine, I know we're about to transition to audience questions. We have time for one more from me.
Yes, absolutely.
Okay, great. So we're going to be, at least according to the Biden administration, and it looks fairly accurate, transitioning to mass availability of the vaccine by early May. I'm curious, and I hate to end on a down note, but I think it's important to be on guard. I'd like to, hear from each of you as we look at mass vaccination, and especially from the perspective of signups and also distribution, which seems mostly figured out, but there's still some issues. What's the thing that you're most concerned about as we move closer to opening that up to anybody? Where are you watching for problems in the system, or are there things that we haven't seen yet that might emerge from that broad opening? And whoever wants to jump on it first.
So we're actually opening up to everyone 16 and up starting next Wednesday. So that was just announced to us the other day from the governor's office. So we're on the heels of that, like we're right there. But my biggest concern, or two concerns actually, one is equity, and are the people that are still maybe at higher risk, are they having the opportunity to sign up? Are they having the same access to appointments as the rest of the general population? People with special medical needs, we really have stopped. We had been prioritizing specific medical needs and age groups, and that will all end next Wednesday. So I know there are people who are still very concerned for medical risk reasons, and just wanted to make sure that everyone has equal access, that all demographic groups have equal access to those appointments and ease of getting those appointments. And then we start watching for where those lower uptake rates are, right? We're already watching different age groups, different profiles, demographic profiles, to see if there are specific groups of people that we're seeing lower uptake rates in. So far here in my local community, we're doing pretty good, but then we start the active outreach and trying to figure out what the barriers are and how to help those specific groups more specifically.
So that transitions us to our first audience question, and I'm not sure if anybody can chime in to specify where those are being submitted, but I think they're just in the chat here. Monica, you mentioned technology for sort of groups with or signups for groups with health problems, other people who might, for various reasons, want to get vaccinated. What are the specific technology measures, and this is for anybody, how do you address technology? Maybe Doug would be the main point person on this one. How do you address technology to make sure that you're reaching, let's say, frontline workers who tend to be perhaps less able to access technology, less able to spend time sitting in front of a computer, for example? What are some measures that have been taken to get the signups to those people who may have barriers? Yeah,
sure. So we've worked with clients to make sure that we use a platform that's mobile enabled, regardless of device, that's inherently mobile enabled. So whether that be their smartphone, whether that be a tablet, whether that be a PC, whether that be a PC at work that's shared that they can log in and create a credential, etc., or providing technology at the vaccine sites. So for example, for walk-up sites, providing laptops or tablet devices, iPads, etc., so individuals can help register themselves in self-service, but also have access to the hardware to do such. The other component that we've seen is making sure that the offering is done so in a manner that's 508 compliant, right? It's accessible for those who have functional needs, screen readbacks, those types of things. But you also still don't pass through the requirement for having information available in multiple languages. And having it available in every language is almost impossible. And so we provide that access obviously in those languages that are most prevalent to those communities. But in the end, no matter what, in the end, you still have to have some level of call center, some level of language barrier support, right, to provide translation, and even to provide registration support for those that are technologically disadvantaged. So most everyone can get access to a phone. We do still see across our country even those types of limitations if we look at some of our tribal communities. And so there still has to be that community outreach, whether that be through faith-based missions, whether that be through community resource centers, public health offices, etc. So no matter how we cross and slice and dice and make as much technology as there is out there available, we still recognize there has to be that human touch and sometimes that human facilitation.
Anybody else want to chime in on that one, or we have some other ones to get to? Okay, so this is I think it's fair to say this is above all of our pay grades. But the next question is about setting priority groups and how that works. And the process itself is, at least on the surface, fairly clear. The CDC has certain guidelines that it has established, and then at the state level, decisions are made about whether to follow those or implement something different. I guess one way to address this to the group we have here, because it is a very sort of high level process. I guess I'm just curious, maybe we can make this very broad. I don't know if there are any insights that the three of you can provide as to how those priority group stagings have played out, and just what we may have learned from going through those different groups.
I can speak to that a little bit. I have sat on some of those committees at the state level and heard some of that discussion, and I can tell you that we've been planning this for quite some time. We turned in our vaccination plans back in September, and that was based on what the state's framework was at that time. Now, that was before the Committee on Immunization Practices gave a framework nationally. So it actually has been a little bit interesting because we made plans not being 100% sure who was going to go first. We had a basic outline though, and it followed the essential worker categories, and then it followed it mostly was role-based categories. It wasn't the age-based one that we landed on at all. And then the Committee on Immunization Practices put out some guidelines. Everything shifted. So we, at the local level, didn't have any idea where it was going to go. So we had to quickly actually develop technology solutions to try to say, okay, how can we be ready for whatever comes next? Because we've never had a total game plan. We don't know week to week. I didn't know as of 2 days ago that the governor was going to announce that it would be open 16 and up. We usually find out like when it happens on the news or right before. So as a local individual trying to figure out how to communicate with those disadvantaged groups, how to communicate with my population, like how to do any of this notification, we came up with like a survey form. We called it a vaccine interest survey. And we used it for a couple of different reasons. One of them was to put people into those buckets that the CDC had outlined would be likely buckets to draw from for the prioritization, because we knew it would be prioritized. We also used it to collect information on who is homebound so that we could deliver to people. And we have actually already, we're just getting stragglers at this point. We've already vaccinated all of our homebound residents. and then to also develop our standby list, because we know once we crack a vial, we have to use all the doses, and the appointments don't always match the number of doses in the vial, and we found that we get more doses out of a vial than was originally planned. So we knew we were going to need a standby list. So we use this interest survey form for those reasons, and also to communicate directly with our population or with those specific groups when we find out that a new group is becoming available. We can shoot that information to them right away, so that they can, get registered and get an appointment and all of those things. But the decision making, I mean, there have been ethical committees, and it's interesting because there's definitely an interplay between politics. It's usually the governors that make the announcements, and then the health group that has, decided on these different factors as being the priority groups. And then you've got, the CDC and the Committee on Immunization Practices, and the federal government. I mean, we saw here in Indiana, we were basically ordered to vaccinate teachers. That wasn't on the priority group for the state. So it's been really interesting. And it, again, is that intersection of, we've got these ethical groups based on like where the mortality rates are, which is primarily the approach that Indiana was using. Where are we going to capture the most people who have the highest risk for death and disability? And then you see, different situations coming into play that upend all of it at the last minute.
One thing you brought up, which I think is very interesting and kind of an emergent phenomenon, is these standby lists for leftover doses because they are, perishable. Is that something that has become standardized in any way, or is it still sort of a case-by-case basis where I hear about people just sort of going to the Walgreens and saying, can I get on a list? What is the status of that system?
I think those have evolved pretty quickly over the course of it. I think most people have tried to have a more organized fashion so they don't have hordes of people showing up at their door at the end of the day. So we never had that because we started out with this list and this expectation that we were using the list. But not every facility was kind of in that. So people have tried a variety of different approaches.
To backtrack a little bit, to either of the other two of you have thoughts about the priority list construction and how that has worked?
Well, I can share my quick. Oh, go ahead.
No, go ahead, Dr. Dai.
Oh, thank you. I just want to be really quick. I just thought initially when CDC developed these guidelines, and every person I know who saw this data said this is way too academic. It's kind of ironic because being academic, I thought this is really too academic to implement.
What you mean by that?
Well, it's theoretically, it tries to make this optimal balance between different priorities, and look at mortality, and also look at the kind of risk individuals are exposed. But just in reality, we just do not have the information infrastructure to implement. For example, how does CVS verify I'm a school teacher? And how does how does my hospital actually know I have multiple health conditions if I'm just recently moved from different states? So we do not have that information infrastructure to implement that. Now, countries who are capable of doing that, like Israel, UK, they have everything. They know exactly who you are, what you have. They're not doing it. Even countries who are capable of doing it, they're not doing it. And we are definitely not capable of doing it. And we started with really complicated prioritizing guidelines that really create a lot of hassle, a lot of big headaches to public health professionals, but also to healthcare providers. So if anything, I would think that the future pandemics, we should really look into something really simple, easy to implement, and not something overly, the effort of trying to optimize things, and we end up getting something impossible to implement. Just one thing, it's impossible to verify eligibility. And in fact, most states are doing this kind of honor system. There's nothing wrong with the honor system, but I just thought that we could have got started with something more straightforward than that.
And that actually was a benefit of us using an age-based system, because it was pretty easy to verify that somebody fit in the age criteria.
That's the only thing we can do. The only thing we can do here in the US. Just verify people's age, get photo ID. We don't have other things, but I thought it's fascinating as that at least comparing across nations, US is the only country who started with this very sophisticated prioritized scheme that do not see in any other countries.
Mm. Doug, you had something to say as well.
No, I was just going to say that I agree with Dr. Dai in his comments. I think some of the structures for prioritization were complicated. Like he pointed out, many of them are unverifiable, right? The obvious challenge is that it's different jurisdictions and different jurisdictions of authority making different decisions on priorities, and so it's confusing, I think, to the general population when their county rule is X, but their news channel main station is in one county over, and that city or that jurisdiction's decisions are Y. And so they're unclear as to what the rules are for themselves based upon where they live and their location. And so it is what it is. I think there are simpler ways to tackle this, but those simpler ways come with relaxing some of the local jurisdiction's authorities and local jurisdiction autonomy. And in some states that's great, in some states that's not, and that starts to fall into political beliefs, which I'll leave alone. And so I think today we have to really try to find solutions that can ebb and flow and navigate different environments and different requirements in a flexible manner. But we're always welcome to learn from our lessons. And I guarantee one of the primary lessons learned from the COVID-19 response will be communication, as it is with every after action review. And I'll leave it at that.
Yeah. Well, thanks to all three of you. I think I'm going to turn it over to Catherine for a few final remarks. This has been extremely enlightening for me, so thank you.
Absolutely. Thank you, David, and to the panelists for sharing your experience and insights and your time today. I really appreciate it. We will be sending out this recording to everyone in the coming days, and feel free to connect with us on social in the meantime. Thanks for joining us, and have a great day, everyone.